You got it on? Or
No, I can use that one.
Oh, it's gone. Oh.
Is that one working? I can do either one.
Good morning. Let's go ahead and get started with grand rounds this morning. It's my pleasure to introduce Dr. Ramon Cestero, who is an assistant professor, hopefully in the next month an associate professor in the Department of Surgery in the Division of Trauma and Emergency Surgery. Dr. Cestero did his general surgery residency in Oakland with Cloud, Oregon, and then did a trauma fellowship while he was in the Navy at UCLA County Hospital, or LA County Hospital, affiliated with UCLA. Or USC. Or USC, yeah, they kind of fight. Which ward do you have? Then came to us and has been in school for now, 2 years now? Mm-hmm. And it's my pleasure to welcome Dr. Cestero talking about endpoints of resuscitation.
Thank you, Dr. Serenik. So today, for those that don't know me, I'm Ramon Cestero. I'm the director of the ICU. I also run the fellowship. I've been here about a year and a half now. And one of the things that interests me is the endpoints of resuscitation, which we use every day, especially in the ICU, to guide our resuscitation of our patients in shock. But we still use lactate, and lactate has been around since about 1960, where we've known that levels over 4 are associated with mortality. But now it's 40, 50 years later, and every morning, a morning report, we have a sick patient, we ask, what's the lactate? And it just shocks me that it's been that long in the age of iPhones and self-driving cars and robots on Mars that we're still using the same things we were using 50, 60 years ago. So what I'd like to do today is kind of go through some of the endpoints of resuscitation that are available, some of the limitations that are associated with each one, along with the benefits. Unfortunately, I can't cover everything in detail. I'd be here for 4 or 5 hours. I don't think anyone wants that. So it'll be kind of a review of what is available today and what we use on an everyday basis. No disclosures. So anytime we talk about endpoints of resuscitation, we talk about shock. And this is actually one of the problems, is how do you define shock? It's been defined as early as 1870 by Samuel Gross as a manifestation of the crude unhinging of the machinery of life. Good description, fairly dramatic, can't really use it at the bedside. It doesn't provide you a lot of information when you're taking care of the patient. In fact, the definition of shock has been so problematic, we've had consensus conferences, and most recently 2006, where again another definition came around that was a little more helpful, failure to deliver and or utilize adequate amounts of oxygen, but again, you can't really take that right to the bedside and apply it to direct patient care. The American College of Surgeons in the ATLS manual, most recently in 9th edition, describes it as an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation, again related to the delivery of oxygen and how well it's used, but no numbers that you can apply to the bedside. However, the American College of Surgeons has classified shock into 3 or 4 stages. We typically talk about class 3 shock. That's the one where you actually become hypotensive. We define that as severe shock. But as you go down the line, there's still, in this third box, there's still some things you just can't use at the bedside. Blood loss of 1,500 cc's. Can't really assess that unless you kind of know how much blood they've lost, but you can't do that initially when you first see them. 30 to 40% blood loss, similar problem. Pulse rate of 120. It's a sensitive indicator, but not a very specific indicator of shock. Many other things can cause tachycardia. And when you get to the blood pressure, which is what we typically associate when patients are in severe shock, it just is decreased. Really, there's no number associated with it. So what do you do with that? You'll notice also we always talk about, or typically talk about class 2 shock, where that's usually one of the first signs of early shock, where you see a normal blood pressure but decreased pulse pressure. And I always, when I talk to you guys, or the residents in the ICU or in the ED, this can be one of the initial indicators you have somebody who might be really sick without them being, frankly, hypotensive. But these are some helpful guides that the American College has put out. However, there are some problems with that, and we're going to talk about it in just a second. There are multiple etiologies of shock in the trauma, critical care population. Hypovolemia, hemorrhagic shock is the number 1, number 2, number 3 cause of shock that we should be concerned about. But we also see cardiogenic, neurogenic, and septic shock as well. The common etiology to all of them, they all include oxygen supply not meeting tissue metabolic demands. So the treatment is similar to some degree. You're trying to replace or provide oxygen to tissue that's not receiving enough of it. Shock, it goes from a compensated to an uncompensated status. Compensated is an early form of shock, the class 1, the class 2, where you still have normal vital signs, and that's mainly due because as you lose some blood or you're in early sepsis, you have catecholamines that are activated, and they cause vasoconstriction, which can maintain your blood pressure and the perfusion. Fluid can shift from the intracellular or extracellular to intravascular compartments to help relieve some of the blood loss that may have been associated with that. And as you progress, you get into partial compensation. This is where you start seeing pulse pressure differences. You're starting to get into oxidation imbalance between delivery and utilization. And as shock then progresses, you become completely uncompensated, where you then get frankly hypotensive. You get cellular hypoxia, severe acidosis, and if it's not fixed, then you get you eventually end up in death. So what does resuscitation mean? It's really restoration of normal physiology on multiple levels. Normally we talk about the standard physiologic values associated with resuscitation, getting them back to a normal heart rate, normal urine output, normal blood pressure, and that's definitely a goal. However, all these can be normal in the setting of tissue hypoxia. And you can still have significant abnormalities at the cellular level despite getting normal physiologic values. This is one of the earliest methods of resuscitation. In the 1700s or 1600s, when tobacco was discovered in the New World, it was taken back to England, and it was used by the Indians here as far as therapy for multiple ailments. And in fact, they used it as an enema, which was then also taken back to England. After a report of a single patient that was resuscitated from a near drowning incident by a tobacco smoke enema, kits became developed, as you can see here. And it's interesting, I mean, you may laugh, however, from that one single study, not different from some studies we've used in medicine to start applying some methods. This became standard of therapy along the River Thames in England for all resuscitation victims. That's actually one of the resuscitation kits. If you had a near drowning victim, you would end up giving them a tobacco smoke enema, as you can see below. And it only took about 80 to 100 years to then get enough studies out suggesting that nicotine was actually toxic to then get this off the River Thames. So history does repeat itself, and we'll talk about that in just a bit. So endpoints have been developed to better guide our resuscitative efforts. Like I said, you can have normalization of vital signs, still have significant acidosis. So now we have some better tools, hopefully. Two general categories exist: hemodynamic markers, usually our blood pressure, or what we use as mean arterial pressure, CVP, central venous pressure, mixed venous oxygenation, pulse waveform analysis, Vigileo, known better to probably the residents, and echocardiogram are some of the main ones. There are others. I'm not talking about all of them today. These are some of the main ones. And then perfusion markers: lactate, base deficit, near-infrared spectroscopy, and then gastric and salivary tonometry I'll touch on as well. So let's start with mean arterial pressure. Why isn't this the only thing we use? It's intuitive. Everybody understands what the mean arterial pressure is. We're familiar with it. We use it on an everyday basis. Every patient in the hospital has a mean arterial pressure associated with him or her. It's universally available. If you don't have a non-invasive cuff, you then have an arterial line, so everybody has it. It's interpretable by the medical student all the way to the senior staff. There's pretty good evidence saying that it's useful. In sepsis, mean arterial pressure goals were used in early goal-directed therapy studies by Rivers in New England Journal in 2001, which showed significantly improved outcomes when that was part of the sepsis bundle. So there is evidence behind it as far as sepsis. In trauma, there's also evidence supporting using hypotensive goals as a endpoint of resuscitation, mainly from 1994, a study from Houston by Dr. Bickel, where the concept here is that if you have a patient with traumatic injuries, especially penetrating, that you're bleeding, why increase their blood pressure to normal or supernormal, where you just cause increased bleeding until you get them to the operating room and control that blood pressure. So what they did is they randomized patients in two groups from penetrating injury. They either got resuscitated in the ED or in the operating room. Those that were delayed resuscitation actually did better mortality or decreased mortality, decreased length of stay, and improved outcomes. So that actually started our thoughts about hypotensive or delayed resuscitation in the penetrating trauma patient. But what are really normal values for mean arterial pressure? Our own Dr. Eastridge published this in 2007. He took a look at the National Trauma Data Bank, over 800,000 patients, and they're wondering, is blood pressure of 90 really the number we should be using for shock? There's really not much data, or if any data, behind that number. We've been using it for a long, long time, though. So what they took a look at is ED blood pressure compared to increasing mortality. And what they took a look at with about 800,000 patients, like I said, this is excluding head injury. As you come down to about 110, your mortality, which you see on the bars here, starts to increase. And that blood pressure wasn't at 90, it was 110. When they started doing subsets of patients that are either below or above 43 years of age, it was even more striking that the blood pressure of your less than 43, your mortality starts going up when you present with 108, not 90. And if you're older than 43, it's up to 117. Not too many patients with pressure of 117 would get our concern up, but maybe it should. Because there's clear data here that your mortality starts going up. So that leads, what is the actual number? And that's one of the cons of using mean arterial pressure as your only endpoint, is that there's no universally accepted goal. And that was just for trauma patients. It's the same for sepsis, neurogenic shock, et cetera. We really don't know what the accepted MAP goal is. And if you live in hypertension, maybe your MAP goal should be even higher. Should it be 120? Should it be 130? Should it be 20% of what your normal is? Well, we don't know what their normal is. So big questions regarding the MAP goal. Also doesn't provide any information about oxygenation at the cellular level. All it tells you about is hemodynamics. The hypotensive resuscitation study I spoke about from Dr. Bickel in Houston. Further studies have not shown an improvement in outcome. Another randomized controlled trial doing a similar study showed absolutely no difference in outcomes. Interestingly enough, in neither study was the blood pressure different, whether you did it initially, or you resuscitated early, or resuscitated late. And most likely that's due to a little bit of discomfort with keeping a patient the blood pressure 60 or 50. It's hard to convince the anesthesiologist that that's the normal pressure you want to keep them at, and patients get resuscitated to probably normal levels. In sepsis, despite normalization of mean arterial pressure in the River study of 2001, there's still lactic acidosis that persisted. It's called cryptic septic shock. So there's still hypoxia going on despite normalization of blood pressure. However, despite data that's not exactly overly supportive of using a MAP goal, the surviving sepsis guidelines are out that you guys should know for your testing purposes, still suggest a MAP greater than 65 in the first 6 hours, and that's what's used at most major facilities around the world today. All right, moving on to central venous pressure, another commonly used measurement. It's been around since I was a resident before then. We know that preload is an important determinant of cardiac output. You need to have fluid rate of pump in order for the pump to work, and that's considered preload. It's really a surrogate for fluid responsiveness, and I bring up the term fluid responsiveness because that's what we use when we started talking about Vigileos and other new technologies. Really, what you want to know is the patient on the lower end of the Frank-Starling curve, and will they benefit from fluid to increase your cardiac output and actually oxygenation out to the tissues. The surviving sepsis guidelines, it's not just the mean arterial pressure that's part of it. A CVP of 8 to 12 is a recommended physiologic target in the first 6 hours, so it is part of the surviving sepsis guidelines and recommended to be used for resuscitation. However, the reliability of CVP as an indicator of fluid status is very, very controversial. And in fact, it probably doesn't mean anything at all. There have been multiple studies saying that, or suggesting that static pressure-derived values, including CVP, do not accurately predict volume status. And there's a big systematic review in 2008, looked 24 studies, comparing or looking at all data, recent data, using CVP as an indicator of fluid status, and there's no association at all between CVP and circulating blood volume. It does not predict fluid responsiveness across a wide spectrum of clinical conditions, including trauma, sepsis, et cetera. And their final conclusion was CVP should not be used to make clinical decisions regarding patient management. And this is out of one of those studies, those 24 studies that were evaluated, looking at CVP in relation to fluid status. And the vertical column is, you see the CVP going from 0 to 25. In the bottom, they followed patients to see if they were fluid negative, down to 1,500 cc's, or fluid positive, 2,000. What you'd like to see is that if they're fluid negative or low in fluid, that their CVP is 0, and if they're fluid high, that their CVP would be high. You'd like to see a line like this. However, there was zero correlation at all between your fluid status and your CVP, so it really cannot be used to determine fluid status. However, we use it almost all the time throughout the hospital. I'm sure the residents have seen. So CVP, not a great indicator of fluid status or fluid responsiveness. Moving on to some of the newer technologies, mixed and central venous oxygen saturation. For systemic oxygenation, it's really a balance between how much oxygen you get to the tissue, which is called DO2, oxygen delivery, versus how much you take out, which is oxygen consumption or VO2. The venous oxygen saturation reflects how much you extract, and there's two methods to determine it. One is by mixed, which is called the SVO2, that you actually put a catheter through the right atrium and out to the pulmonary artery. That's where you have blood coming from the superior aspect of the body along the inferior aspect, and that really is a global marker of what your oxygenation is. But you need a pulmonary artery or Swan-Ganz catheter to really get to that point. Or the other method is a central venous oxygen saturation, SCVO2, which is really just done by a central line. It can either be in the subclavian vein, or more important, or you'd rather have it closer to the heart. Usually ends up being in the SVC or near the right atrium. Two methods to obtain it. Normal SVO2 is typically around 70%, so we extract about 30% in a normal status of the oxygen delivered out to the tissues. And low values will then suggest hypoxia because you're taking out more tissue or more oxygen than you normally would need. So as far as the SVO2, meaning the mixed venous, what are some of the pros in using this? The values do reflect total body oxygen extraction. Again, it's in a mixed venous status as you're taking the blood from the superior aspect and inferior aspect of the body, or it's mixed out in the pulmonary artery. So it really is a true mixed venous sample. There are a lot of studies that have suggested that there's benefit to using this as an endpoint of resuscitation, and not just in cardiac patients, but in trauma patients, septic patients. So really, there is data supporting its use. And a low SVO2 has been shown to be predictive of poor outcomes. So fairly good data to use this as an endpoint of resuscitation. However, there are some negatives that come along with it. One is you have to use a PA catheter in these patients to get a true mixed venous sample. And although this was a standard procedure when I was a resident, I think the studies shown that up to 40% of patients in a surgical ICU that were sick had a Swan-Ganz catheter placed. It's not nearly as placed as frequently now. And that could be a whole other discussion about the Swan-Ganz catheter and where we are with it today. But there are some complications associated with it. Increased risk of PE has been reported. Cardiac perforation during placement has been reported. The inability to read it correctly by physicians been reported. And again, it could be a long discussion, but it does require a PA catheter with complications associated with it. Secondly, normal SVO2 values don't guarantee that you have adequate tissue oxygenation. Mainly in sepsis, there's a concept of dysoxia where cells may not be able to extract oxygen. So even though you're delivering oxygen out to the tissues, if the tissues are sick, they may not extract them, so you may have still normal values when you get back to the pulmonary artery. There's also microcirculatory shunting, just like there is in the lung, that you get the tissue out there, or the oxygen out there, but you shunt the capillaries, and it ends up coming back. So having a normal value doesn't really always tell you that you're hypoxic. There has not been any data showing that there's independent predictor of survival, and there's really no benefit in studies comparing lactate and SCVO2 based resuscitation protocols. And SCVO2 is discussed here instead of SVO2 because most of the recent studies have been associated with the central line, not so much a PA catheter. Lactate has been shown to independently predict survival. So along the same lines, but a little bit differently, we're still talking about oxygen extraction, but now obtaining it through a central line, SCVO2. Again, it requires a central line to be placed either in the SVC or the right atrium. This catheter here, which comes up, okay. There's a couple catheters you can use. One is just a standard catheter that you just intermittently withdraw fluid from or blood from and send that off for your intermittent SCVO2 measurements. There's another proprietary catheter that was used in the 2001 River study that there's a patent on it. It belongs to Edwards. It's very unique to that study, had great outcomes. I'm going with bias here. But that catheter actually does continuous measurements, so there's a couple types you can use. It does provide regional versus global oxygenation, so you're measuring from the upper half of the body, not really the lower half. However, the closer you are to the heart, the better your measurement, the better correlation you have with your mixed venous. In fact, if you're 15 centimeters away from the right atrium, it'll read it by about 8%, but if you're at the right atrium, it's only about 1%. So it does correlate the closer you are to the right atrium, but there's still some debate on how well it correlates. And now you can see here in this graph from one study that on the top line you have the SCVO2 sent from a central line. Bottom graph is from a mixed venous, and the trends go fairly well, but overall, in general, it overreads it by about 7% or so. Some of the benefits of using this, there are studies suggesting that the values do decrease. You do have evidence of hypoxia when you're in cardiogenic and hypovolemic shock, so it is a marker of shock. The biggest pro for this was, again, the early goal-directed therapy study from 2001 from New England Journal, where they used the SCVO2 from the proprietary line I discussed as an endpoint for resuscitation. And in that group, they had an absolute reduction in 28-day mortality of about 16%. It was very impressive at the time. And this actually became another part of the surviving sepsis guidelines, not just a MAP goal, a CVP goal, but this is the third goal of SCVO2 greater than 70%. Some of the cons, it does require a central line when patients may or may not need it. The values, like I mentioned, do not directly correlate with the SVO2, which is really our gold standard for oxygen extraction. It doesn't represent global oxygenation. Again, you're only measuring the upper half of the body if it's in the subclavian vein. And there's significant controversy regarding early goal-directed therapy study that I've mentioned several times, and using the central venous catheter for your SCVO2. That was a single center study with a high amount of selection bias. When they've gone back and done a post hoc analysis of that study, they realized there were several dozen patients that were not included, and if they had been, the study would not have shown a significant difference. There was reported mortality that was 20% higher than other studies. Their mortality in their sepsis group was 46%, where most are about 28, 29. So significant problems with that study. And other studies since that time, since 2001, have really shown a significant improvement in early goal-directed therapy without using the SCVO2 as your endpoint. This study just came out about 2 weeks ago. It's actually the third of 3 randomized controlled trials trying to debunk early goal-directed therapy and using SCVO2 as your endpoint. It was a randomized multi-center trial, just like the other 2 were, using early goal-directed therapy, including the SCVO2, versus usual care in severe sepsis. The usual care group was allowed to put in central lines. They just couldn't use mixed venous oxygenation or venous or SCVO2 as your endpoint. Over 1,200 patients, 56 hospitals. What they found was no difference at all in 90-day mortality. And in fact, the early goal-directed therapy group that they were using as an endpoint had received a lot more fluids. They received a lot more vasoactive drugs, a lot more transfusions, worse organ failure scores, and longer ICU days. And this is despite the fact that the usual care group, about 50% did receive a central line, but none of them actually received SCVO2 measurements. So it's probably not necessary. It's now the third study that has really proven that. You don't need to follow that for resuscitation. There's the results. As you can see, there are really no difference between usual care and early goal-directed therapy, and it's been, like I said, fairly well shown now. So overall, for mixed and central venous oxygenation, they do represent oxygen balance. There is data, especially in the mixed oxygen venous studies, that does represent hypoxia and the need for continued oxygenation or resuscitation. However, it doesn't provide any information about your actual etiology. Doesn't provide information about your microcirculation, especially when you're having either shunting or some dysoxia, especially of sepsis. And the data supporting use as an endpoint, although it was very strong back in 2001, now it really it's pretty much been debunked. The surviving sepsis guidelines, however, still recommend SCVO2 greater than 70% or mixed venous greater than 65, but the 3 large multi-center randomized trials really don't show as a benefit. However, if it's available, if you are comfortable using it, if you already have a central line or a PA catheter, they are reasonable goals to use because they are associated with hypoxia and continued resuscitation. Again, some of the newer technology, and this is something that we use fairly commonly here, arterial pulse waveform analysis. So this is based on pulsus paradoxus, or more specifically, the reverse pulsus paradoxus. Pulsus paradox is one of those things I typically have to read if I haven't talked about it with the residents for a while because I forget what it is. But in general, if you're spontaneously breathing, you take a deep breath, your blood pressure drops. When you exhale, your blood pressure increases. Reverse pulsus paradoxus is the opposite of that. When you're on mechanical ventilation, your blood pressure increases when you give a positive pressure ventilation, and it decreases during expiration. But using this in combination with stroke volume, which is measured by proprietary algorithms, where it measures the area under the curve of your arterial waveform, you can measure then stroke volume variation. So that the drier you are, the more volume depleted you are, the more variation there is from breath to breath especially on mechanical ventilation. And there's another way of measuring not exactly fluid status, but fluid responsiveness, and we'll look at that in a second as far as the Frank-Starling curve. There's multiple methods available. There's a PICO, the LIDCO. We use the FlowTrack here by Edwards. All have their own proprietary algorithms, all have their own ways of zeroing and their own limitations, but I'll talk a little about the FlowTrack that we use here. Again, it uses the area under the curve at your stroke volume max, which is usually at the top of inspiration when you're being mechanical ventilated, and expiration, and it determines a mean. This is the machine that usually comes with it. It gives you a nice reading. And this is just another graphical representation of what the machine does. From a beat-to-beat standpoint, where your stroke volume goes up and down, it'll measure the maximum and the minimum and come up with your SVV percentage that'll come up on the machine. And what you do with that is really the more variation you have, usually we use about 10-15%, you're on the low part of the Frank-Starling curve. So remember, Frank-Starling curve is stroke volume on the vertical axis, preload on the bottom. And as you increase your preload, you extend your sarcomeres on your heart, and you should really optimize your ability to contract. So if you have a large SVV, you're probably on this low part of the curve and you're fluid responsive. So you give some fluid, your SVV goes down a little bit, you measure it again, and you finally get to a point where your SVV, your stroke volume variation is then below 10%. And usually at that point we feel the patient's now at least fluid resuscitated. And again, each of the different proprietary algorithms tells you a little bit different information. How well does it respond fluid responsiveness? Actually very well. This is using different methods, but in fact, if we're just using SVV as a marker, it's actually pretty good. So this is a systematic review and meta-analysis over 25 studies looking at SVV and how well does it evaluate fluid responsiveness. Most of these studies are small, non-randomized. A lot of this is done by anesthesia colleagues in the operating room. So not a lot of data, but there is a general consensus that it works relatively well. And one way to measure that is using the area under the curve for your ROC, receiver operating characteristics. And the way to read that is anything over 0.4 is considered to have a good diagnostic accuracy as far as a test. So you can see here 0.93, 0.94, the hemodynamic monitoring using the Visual-AO, 0.96. So all usually for most of these studies, a fairly good accuracy of using it as a evaluation of fluid responsiveness. What about outcomes? Only, like I said, 3 small trials. There's not a lot of information supporting this, but they are randomized controlled trials, single center, mostly intraoperative. They have shown reduced postoperative complications and a decreased hospital length of stay. So not a lot for the ICU or the critical care population, but it is suggestive of improved outcomes. There are some significant limitations with using this, and the acronym can be memorized as SOS. First S stands for either small tidal volumes, usually less than 8 cc's per kilogram, and spontaneous breathing. The O stands for open chest. And the commonality between these two is that these all cause small changes in intrathoracic pressure. In order to really see those differences in SVV, you really need to have semi-large lung volumes, and that's the way those algorithms were determined. So less than 8 cc's per kilo presents a problem for us when we're using ARGNet criteria to ventilate our patients at 6. So again, those algorithms weren't designed for this, so that can be a significant limitation in our population. If you have somebody who's not intubated, that's a significant limitation. Really can't be used as a great marker because the studies or it wasn't designed to use that way. And open chest, same thing. You don't really have the intrathoracic changes you need to have an SVV. For the last S stands for sustained cardiac arrhythmia. Most commonly, that's atrial fibrillation. Again, remember that machine needs to kind of have a steady, normal rhythm in order to measure the area under the curve for each arterial waveform to get a good number. When you're in atrial fibrillation or any other arrhythmia, you really can't do that. So the ideal patient would be one who's mechanically ventilated, high tidal volumes, no spontaneous respiratory effort, so paralyzed, which is pretty rare in our ICU, and no arrhythmia or RV dysfunction. So pretty unique population, not saying we don't have those, but if you're going to use this technology, this is the kind of patient you really need to have to really trust those numbers you're going to obtain. Even if you have that patient, you need an adequate waveform. So if you have a flattened waveform, really you can't measure the area under the curve. So you need to make sure that it actually is good when you look up on the monitor. And like I said, there's limited large or multi-center studies suggesting it's used as an endpoint. But as those come out, it may end up being one of our better endpoints of resuscitation. I'm going to only briefly touch on Doppler, just because I think it is potentially something that's going to be coming down the line as a useful tool. It does measure both static and dynamic parameters, so it gives you an estimate of volumes as well as cardiac output, stroke volumes, et cetera. It's been found in multiple studies that changes in aortic blood velocity when you're mechanically ventilated will predict fluid responsiveness, similar to your visual AO numbers. And in the spontaneously breathing patient, again, similar to the visual AO, it's really kind of limited. And what they do is similar technology where they took an area under the curve and they look at velocities. To be honest, it's a little more complicated than I expected when I first looked it up. But there are studies where it does give you fluid responsiveness. The significant limitations, however, are probably lack of training in personnel. I wasn't specifically trained this during my fellowship. Most fellowships maybe touch on it a bit. We're starting to do that more. But really there's lack of training in personnel to do echo that can actually read velocity time intervals and some of the more advanced techniques you need in order to use this as a resuscitation endpoint. There's a long learning curve associated with it. It does provide non-continuous data. It's not something you just leave in and have it up there on a monitor for 3, 4, 5 days while the patient's in the ICU. You can leave some of the newer probes for longer periods or for periods of time over 12, 14 hours, but it's not something that you can just put on and leave on. So it is non-continuous. And really, as an endpoint resuscitation, there's really no data out there whether we should be using this. So that should probably be coming in the next few years. So that's the hemodynamic markers. Again, there are others, but for interest of time, I curtailed it there. And now we're talking about some of the perfusion markers that we're more familiar with, including lactate-based deficit, near-infrared spectroscopy, and the tonometries, which is either the gastric tonometry or sublingual. Lactate, again, remember this is part of my title, so I'm going to talk about it a little bit. You'll see why in a minute. Yeah, remember, it's a glucose metabolism byproduct. As a pyruvate is generated, you either go in an aerobic pathway or anaerobic pathway. When you go to the aerobic pathway, which is more efficient, you end up going in pyruvate goes in the mitochondria, and through oxygen-dependent processes, you need to have oxygen around, you generate 36 ATP. When you're in a hypoxic environment, like in shock, it doesn't enter the mitochondria, and it stays in the cytoplasm, and it only generates 2 ATP, but as a byproduct, you end up with lactate. It's a balance between production and clearance. The vast majority is cleared by the liver. About 10% is cleared by the kidneys. So anytime you have hepatic or renal disease, you may have artificially elevated lactate levels. And we use it really as a marker of anaerobic metabolism. I put this graph in here just to show that this is just from runners that had measured lactate after running at several speeds. And you can easily get increases in lactate levels, which are cleared very quickly if you have a functional liver and a functional kidneys. And in fact, for marathon runners that collapsed at the end of their run, they've measured their blood lactates, and over 95% of them have elevated lactate levels, which is not surprising. But it is generated quickly and can be cleared very quickly depending on anaerobic metabolism. It's been known for a long time, like I mentioned, that lactate levels over 4 since the 1960s are associated with mortality. But really, more importantly for us, and this has been shown in multiple studies, is just one of them, the time to correction of increased lactate is really associated with mortality. There's a retrospective study of about 188 patients in the surgical ICU that required some type of hemodynamic monitoring. They stratified patients retrospectively into 4 groups. Those that didn't clear their lactate at all during their stay, those that cleared lactate back to normal between 48 and 96 hours, between 24 and 48 hours, and less than 24 hours. Mortality is in the very top row, the initial lactate levels in the very bottom. So you can see the patients that didn't clear their lactate at all had 100% mortality. But as you start clearing it a little bit quicker, 48 to 96 hours, your mortality is cut by half to about 42%. If you clear it within 24 to 48 hours, it's down to 13%. And if you clear it within 24 hours, only about 4%. The lactate levels were higher for the group that didn't clear, and it also decreased, as you might expect, as you had improved mortality. However, on univariate analysis, it showed that time to clearance and the lactate level were associated with mortality. However, on multivariate analysis, only the time to clearance was associated with mortality, suggesting that it's an independent associated variable with mortality. It's been lactate clearance, and like I said, there are multiple studies that will show that for a variety of patient populations. More recently, it's been looked at as a substitute for the central venous oxygen saturation. Like I said, there have been a lot of doubts about that Edwards study from 2001, and can we use less invasive technologies to really give us the same amount of information? There's a multi-center randomized study from JAMA, came out in 2010, looking at lactate clearance versus central venous oxygen saturation as a goal. They compared lactate versus SCVO2 in severe septic patients. Remember that the Surviving Sepsis Guidelines gives you guidelines for CVP, MAP, and SCVO2. So what they did was normalize to the CVP and MAP, really just looking at SCVO2 versus lactate. They had two groups, one that they guided to SCVO2 of greater than 70%, or just a lactate clearance of 10%. They had a significantly lower mortality in the lactate-guided group, 17% versus 23%. And this is not the only study to have shown that. As far as using lactate alone for intensive care versus other standard therapies, another randomized controlled trial from 2010, look at four ICUs, including medical and surgical patients. They had all patients that had a lactate initially over 3, over 350 patients. They had two groups. One is just guided by lactate levels, that they had to decrease them by 20% every 2 hours for initial 8 hours versus not following lactate at all. The second group, the providers had no idea what the lactate level was, but they used any other resuscitation target they wanted, whether it was blood pressure, urine output, SCVO2, etc. The lactate-guided group had decreased mortality by 10 points, 34% versus 44, a shorter ICU stay, and they were weaned faster from the ventilator and inotropes. Again, a lot of good data suggesting that lactate is a very good marker for an endpoint resuscitation. So overall for lactate, it's easily measured laboratory value. It's available in every hospital. It provides a very good estimate of hypoperfusion and anaerobic metabolism. There's level 1 data. You haven't seen me write a lot about level 1 data for any of these other technologies, but there is significant level 1 data using lactate as an endpoint. But there are some limitations, and they're not insignificant. It is cleared by the liver and kidneys, so if anybody in liver failure or renal failure will have artificially elevated or potentially have elevated numbers. Anybody in seizures will have elevated lactate. Asthma, just by the work of breathing, can elevate your lactate. Cardiac arrest, burns, DKA, thiamine deficiency, just because of lactate metabolism. Several drugs can do it, including alcohol, which is not rare in our patient population, especially for trauma. And lung inflammation has even been associated with it in at least one study. So you need to know about these when you're going to be using your lactate as an endpoint. It also may lack sensitivity, especially in mesenteric ischemia, closed loop obstructions. You may not have that lactate that actually makes it back into the circulation for you to measure. So it may lack some sensitivity in that patient population, as well as some septic populations. But overall, a very good marker. Base deficit. Similar story to lactate, a lot of good studies suggesting that it's useful as an endpoint. The formal definition of base deficit is the amount of base required to increase your pH of 1 liter of whole blood back to a normal, 7.40. It's a marker of anaerobic metabolism. Really use it as a surrogate marker for lactate because it's more easily available. It's part of the ABG. When you send off a lactate, you typically have to wait until it comes back from the lab. So it's difficult to use in the ED when you have a sick patient, you're trying to get an estimate of their hypoperfusion. Normal values are between -3 to +3, and it's been stratified typically in a mild being 3 to 5, moderate 6 to 14, and severe greater than 15. Multiple studies supported its use, at least in trauma, as well as the general surgical population. It's an independent predictor of mortality, and ICU and hospital length of stay. Severity of deficit, how bad your base deficit is, directly correlates to how much volume you're going to need within the first 24 hours and how much you've bled for hemorrhagic shock. Failure to normalize, similar to lactate, correlates well with mortality and organ failure, and it's a good marker for complications. The worse the severity, acute renal failure, ARDS, multi-organ failure, and coagulopathy. A lot of data supporting that. From an interesting study from a couple of years ago, though, it's actually even been suggested to be used instead of the ATLS definitions of shock, to use actually this as a marker of which category in. So this is a German study. What they use their trauma registry, which has about 16,000 patients. They stratified their patients into class 1 through class 4 shock using ATLS criteria, and then they used the base deficit definitions, being class 1, anyone base deficit less than 2, class 2 being base deficit 2 to 6, class 3 base deficit 6 to 10, and number 4, base deficit greater than 10. And when they compared these groups, in terms of blood transfusion, and here you can see on the left is the ATLS class 1 definition, and this is a base deficit definition, so this would be base deficit less than 2, 2 to 6, 6 to 10, and greater than 10. It was a much better predictor, by following the black lines here, of who required a blood transfusion, who required a massive transfusion, and mortality. So they're suggesting that this could be used instead of your standard ATLS definitions as an early marker of shock and maybe a better predictor of who's actually sick, with fairly good results here. Some limitations, similar to lactate, can be affected by some of the drugs you give. If someone receiving sodium bicarbonate will affect the base deficit. Hypothermia, hypocapnia will also affect it. At least a couple of studies have shown that alcohol can worsen your base deficit for a similar degree of ISS and hemodynamics, so it could complicate patients who come in intoxicated. Other causes of acidosis can affect the value, especially renal failure, not rarely seen in our patient population, DKA, CO2 retention, and it doesn't correlate well directly with lactate levels. So if you're using lactate and base deficit, you kind of have to use them almost independently. But very good marker for hypoperfusion. Another newer technology is near-infrared spectroscopy, or NIRS. What it does, it's a special kind of light that measures hemoglobin oxygenation in the tissues by spectrophotometry. It measures oxygenation in chromophores that are in the tissues. What it does is basically you put this little pad on the thenar eminence. It attaches to a machine similar to a Vigileo, and it gives you a little readout of oxygenation status. However, it gives you, it's really regional oxygenation. Really, it's a thenar eminence it's reading. So there's questions of whether this is really reflective of total body oxygenation. But it is non-invasive. It does reflect oxygen consumption. It doesn't require pulsatile flow. So it is very easy to use when you do use it. Unfortunately, it's not a very sensitive indicator of hypoxia. When they took a look at patients who donated blood, the ones that gave 500 cc's and actually became a little bit hypoxic and hypotensive, STO2, which is the NIRS value, did not actually pick that up, so it's not very sensitive. In the septic shock population, only about 50% of patients that are actually in septic shock had low values, and they really weren't associated with heart rate, MAP, or SCVO2. So the data really is not very good. It's overall inconclusive. This is one study looking at this technology in trauma patients, and so they had patients in different classes of shock. They had normals, no shock, mild shock, moderate shock, and severe shock. And the NIR value really didn't drop significantly until you really were in severe shock. So probably not a good marker for the early types of shock, possibly useful in severe shock. So overall inconclusive in various shock etiologies. The thenar eminence may not be the best reflection of total body oxygenation, and so at this point, really, you can't really recommend it as an endpoint of resuscitation. Gastric tonometry, this was actually something that was big or coming into play when I was a resident. Really, we thought this was going to be the newer and better technology that we're going to use to supplement or replace Swan-Ganz catheters. Really, it's just an NG tube with a specialized tip on the end. It measures CO2 in the gastric wall. The concept here is that in the setting of shock, you really are not perfusing some of the non-essential organs, such as the stomach. You take a measurement out of this or sample, and really you measure the CO2 and the gastric pH. The more acidotic you were, the lower your pH, the more likely you were in shock. It was a difficult calculation, and really to this point, or to this day, it's not known whether it was really accurate, but there were some technological issues with it as far as using that instrument. It was, however, a sensitive predictor of outcomes in multiple patient populations, trauma, sepsis, cardiac, ICU, so the technology will probably work. However, the multiple studies not shown an improvement in outcome when you use it as an endpoint, including prospective randomized trials. So even though as a predictor, it's not really good as an endpoint. And there are, like I said, some technical limitations with at least that technology and the calculation itself for measuring the gastric pH was probably flawed to start with. There are some hopes with using that same concept in the sublingual or in the mouth. because it should be the same. If you're in shock, you're not perfusing some of the non-critical organs, such as the oral cavity. So mucosal PCO2 may end up actually giving some of those values. It's easy access, relatively non-invasive. It's just a probe, goes inside the mouth. It is able to diagnose hyperperfusion. There are a few studies out there in sepsis, hypovolemia, saying that it does pick it up. However, really no better than our current standard methods, being base deficit and lactate. So until there's a clear benefit, really it's not in use yet. So as a quick, I know it's a very quick overview of multiple technologies. Each of those technologies could probably be their own grand rounds. I didn't touch on Swan-Ganz catheterization because, again, that could be an all-day event here. But I'll leave it up to you. Have we progressed beyond lactate? We're still asking that question every day. Morning report, what's the lactate level? There is level 1 data to support it, as opposed to some of the other technologies. We're really, we're not quite there. So in conclusion, there are multiple technologies available to us to guide our resuscitation. However, there's no one single resuscitation endpoint we can use. They all have their benefits and limitations. It's still guided by multiple clinical tools, ranging from normal physiologic values, which still should be one of our goals, to some specialized equipment, especially to pick up that cryptic septic shock or cryptic shock that may not be appreciated by normal values. And really global markers of oxygenation perfusion, whether it be lactate, base deficit, or SVO2, they are practical, easily available, and useful as supplements to experience clinical assessments in the resuscitation of our patients. And with that, I'll open up to any questions. Thank you very much.
Is that helicopter landing or crashing?
I have no idea. I think it was pasted on.
Excellent. Any questions? Yes, Dr. Dent.
So 3, I guess, questions or comments. Start with the easiest one, I guess. The river study, once someone kind of helped me interpret that, it seemed like it was really a study of resuscitation versus neglect. And the subsequent studies that have kind of shown it to not be as helpful were, you know, different forms of resuscitation. And so it seems like basically in the septic shock patient, what I can conclude from the literature in the most recent article I haven't read yet is any form of resuscitation is better than neglect. Is that really about the bottom line on that?
I agree with that statement wholeheartedly. The river study has been looked at a lot by multiple groups. It was, I think, usual care, which is what now they've looked at in those 3 multi-center randomized trial. Usual care is now different than pre-2001, where neglect is no longer the case. We do now give antibiotics earlier. We give fluid resuscitation earlier. We do put in central line still, even in these multi-center randomized studies. So it's not that we're not doing anything involved in the river study. It's just some of the technology and guidelines they suggested had little data to begin with. Because there was such a significant difference in mortality from that one study, it did get taken up as a bundle, and now it's difficult to unbundle what each of those things are, or what the contribution of each of those interventions. Over the last 10 years, it has been unbundled, where SCVO2 is probably not necessary, CVP is not useful, MAP is probably still a good resuscitation endpoint, but what MAP number? It may not be 65, but it may. But the fact that the patients are being addressed early on, I think, is providing the significant improvement in outcomes.
Yeah, because for the residents, what was happening, I guess, at that particular facility prior to 2001 was, you know, the ER would make a diagnosis of sepsis and sick enough to be in the ICU, and they would call the medicine ICU for admission, and then the patient would sit in the ER, you know, for hours before the medicine ICU team came down and started actually resuscitating and that sort of thing. So it may have been more of a local system issue than it was really resuscitation, global type picture issue. Your CVP versus intravascular status graph, I've struggled with that for a long time. I've discussed this with like our nephrologists and so forth, because it suggests that de facto, if you've given someone more fluid than they've put out, then by definition their intravascular status is their volume overloaded. And when you see patients, and maybe I'm trusting CVP too much, but even when we're using PA catheters, when you see these patients that you've given, 20 liters of crystalloid to, and their PA pressure is 15/4, okay, they're not intravascularly overloaded, and that patient has a CVP of 3. They're not intravascularly overloaded, and that patient would have fit on your graph as someone who got volume overloaded but CVP of 3, therefore the CVP is not accurate. And what they're doing is they're third spacing the fluid out extravascular. And so I'm trying to figure out if I should totally write off CVP, or if my understanding of how that works is wrong, or what's the deal?
That's a difficult question. From the studies, it's worthless. And there have been not just the recommendation from that study, for the international consensus of shock in 2006, also recommended that static pressure-defined values, such as CVP, are not useful for estimates of fluid status. Now, whether in the immediate setting where you give a fluid bolus and it goes up from 3 to 8, and you consider that patient fluid responsive, that might be a little bit different. However, it's probably more accurate to say you've given that patient a fluid bolus, and now the blood pressure has increased, or SCVO2 has decreased. The other thought behind why it is that we may give patients a volume load and CVP doesn't change is we assume that once you give blood volume that the superior and inferior vena cava are going to stay kind of static, and that's going to be reflected in increased pressure. Well, it may be that it just dilates. And so using a pressure to evaluate volume, that might be the biggest flaw. So, I mean, unfortunately, I can't answer that question definitively, but what the data shows from multiple studies and large group recommendations is that it probably should not be used as a marker or a guiding endpoint.
Okay, and then the last question. I've been teaching for 2 decades now, that with all these endpoints, if you're using all of them, including the more basic ones you didn't cover, like urine output and perfusion of the big toe and mental status and all those things, if anything suggests they're under-resuscitated or not perfusing well, and a bunch of things suggest they are perfusing well, you should default to assuming they're not perfusing well, because none of these are particularly sensitive or specific. And so if you're getting any data at all that says they're not perfusing, you're probably better off defaulting to believing that data. And I think young clinicians in particular get reassured by a little good data and ignore the bad data. And I think the more senior clinicians do the opposite. Has that been your take?
No, I totally agree. None of these are perfect. And especially when you use more of them. So now if you have somebody with a central line, you're getting a CVP, maybe you're getting mixed venous, you're using your lactate, you're using a base deficit, maybe you have gastric tonometry, not that we have that available. But when you add these all in, there's a chance that one of them is going to be abnormal. And although the majority of the data may support that the patient's doing well, if you do have one abnormality, you do have to go seek that out. Now, maybe a limitation of that particular value, but you have to know what those limitations are. So without that information, you may not be able to use it correctly.
So clinical savvy on top of everything, where you're looking at everything, trying to put it in perspective.
Yeah,
you can't be reading it from afar.
Yeah, the best doctors I know tend to be pessimists. And so I've kind of learned from other folks around here that if you take a pessimistic view, you won't miss things. I'm not saying you're going to be necessarily right more often, but you won't miss things as much. And so that has worked for me. And for everybody in the audience, I would commend to you to reading Dr. Cestero's chapter in Surgical Clinics of North America that just came out on this exact topic, where he goes into a lot of this and a lot of references and the background studies and so forth. And so if you want to get into this in more detail, that would be an excellent
You might have to read it to answer the 4 questions he asked. Brian left, but his paper was in Traumatized Soldiers.
Journal
right?
from
And I was really surprised at the difference. Did he explain it? Is there any explanation? Or was just an interesting finding that, somebody was not they were in shock at 110 or 120?
Well, his explanation, we probably have the wrong number. It's probably not 90. That was actually his title, that we probably have the wrong definition of what we define as hypotension. And we probably should be using a higher number to have a higher concern for patients that might be in shock, where right now we don't think patients are in shock at lower
Because
numbers.
I would have thought maybe that was with the civilian population, not a bunch of young combatants with, hardened arteries, and we might be getting abnormal readings.
I mean, he had the group was over, I think, 800,000 patients, and when he did subset it into the younger group, although 43 is not typical combat military population, it still showed that 108 was the inflection point where mortality increased.
Dr. Stewart.
So beautiful summary, Ramon. And to your question, Ken, if you look at the outliers, so it's going to be in young, healthy people, which would be active.